So thanks to all the speakers for some really terrific and provocative, but also I think some very, very practical insights. So I'm going to have one follow-up question for each of the speakers, and then I'll open it up. So if folks want to get ready in a minute or two to ask your questions. And we are told that we're going to conclude at 2:30 sharp. So we've got about 18 minutes, 17 minutes. So my first question is for Jessica Briefer-French. You talked a lot about how to engage both purchasers and regulators to sort of align the activities that they're engaged in terms of delivery system transformation with some of the standards that would support culturally and linguistically appropriate services or health literacy. We heard two examples, covered California and now New York DISRIP, where we're beginning to see that alignment. Can you think of other opportunities that you might predict or hope for over the horizon?
So I think the marketplaces are great environments where these issues are going to be important, and certainly Medicaid as well is. Can you hear me? Medicaid as well is going to be an important place because that's where really the diverse communities get most of their public funding. CMS, as the Medicare payer, has the greatest clout through the Medicare program, and they've already begun efforts in this direction. And I think actually have a real opportunity to be a convener of sort of a multi-payer initiative, and I think as Marshall indicated earlier, and others have spoken as well, that alignment and integration across payers is going to create the best opportunity, I think, for consistent, aligned efforts and common payment incentives where you've got a variety of purchasers defining value in similar ways where measurement sets can also be aligned.
Great. And then, so Sarah DeGia, you talked a lot about how you really partnered with community-based organizations, especially on reviewing the in-language materials. Can you talk a lot about, we haven't really talked about sort of the community-based partnerships and how patients and consumers themselves might get more engaged in supporting these kinds of efforts. Can you say a little more about how you're supporting those activities in community-based organizations and with consumer and patient organizations?
Sure. CPEN has been engaged since 2007, when California itself was looking at reforming access to health care. We started early on recruiting some organizations because when we looked at who was at the policy table, it did not really represent the interests of Californians, the diversity of California. And so from the very beginning, we had worked with various different organizations around the state, and we were able to actually tap into some resources through some of the very generous supportive foundations like the California Endowment, California Wellness Foundation, who were able to provide us with resources to then actually resource and provide some capacity building for those organizations. Many of them are engaged at the local level. They were not engaged in statewide policy efforts at all. And so by being able to provide small grants to individuals, we were able to get them the capacity to be able to come to Sacramento, for example, and tell the story. Somebody mentioned earlier, the data kind of frames the conversation, and it's the stories that really change the hearts and minds. And so being able to bring individuals to Sacramento to really talk about what the direct impact would be in California. And so that has been a model that has continued to work over the past couple of years. I think now as we're looking at healthcare system transformation efforts, that there is a real important emphasis on how are you engaging community, how are you engaging stakeholders. I think there's, through community benefits assessments, there are, efforts through the CalSIM model, various different states' CalSIM model. I think even, to the extent that it can be incentivized through other kinds of mechanisms as well, that, the basic idea is that we need to, as Marshall pointed out, you need to actually hear from the population itself that proxies, are not going to be, they can provide one perspective, but it's not necessarily going to be the right perspective. And so, as we move forward in looking at health system delivery transformation efforts, and particularly at how do you really engage that consumer perspective, it's, what are some of the capacity and resources that are being provided to community members in order to participate in this. I think Stacy also mentioned making sure that it's a part of the leadership and the governance, going forward as well. And, even in California, we're looking at things like the all payer claims database, transparency efforts, again, really making sure that consumers understand the system, that we're creating this culture of change, and providing some resources for community members to move forward.
So, Marcia Chin, you gave us a lot to think about and a lot of different frameworks. One of the final things you said was paying attention to some of the safety net providers. And again, just as I think patients are not the same, providers are also not the same. Do you want to say more about, especially in finding answers, working with the community health centers and some of the other providers, what additional burdens and hurdles they might have to be part of this? They're obviously serving this population, but they may have some other capacity and structural challenges.
Right. So despite the Affordable Care Act, we still have a system set up where particularly safety net providers have the most challenges perhaps of any different organization in terms of having very challenging patients to care for, both the clinical morbidity as well as the socioeconomic, cultural challenges, but also then limited resources. And so we have to be careful to make sure that they have the resources to be able to do their mission, but then also to create incentives and systems that don't make things worse. So I think Dennis made this point about also looking for unintended negative consequences of different policies. So there's that side of it also, but then even more importantly, I think proactively, how can we explicitly design a system so that we maximize the chance that good things happen? And because, again, it's a resource-constrained setting, we have to think specifically about the top policies and resource allocation that would benefit that.
And then finally, Stacy Rosen, you told a great story about how your system really has been on this road of integrating these issues of diversity, inclusion, health literacy, cultural competence, and language access into the system as a whole, and leadership has clearly been a part of that. Do you want to say more about what's motivated those leaders? What has really gotten their attention to sustain that kind of system transformation?
Oh, that's a great question. I think it's a combination of doing right and doing smart. And the doing right comes from our president and CEO, who comes to this as, an immigrant to the United States, a social worker by background. If any of you have met Michael Dowling, he is just mesmerizing to listen to. So I think the just do the right thing is a large part of it. But I think that he and our leadership team, both clinical and administrative, see that the business reason to do this is critical. And jumping across the chasm too late will put each of us into a financial problem. And I think the timing of how we support the initiatives that don't have an easy and early return on investment has been some of the brilliance that I think this health system has put forward. It's for both reasons, really.
Great. So I invite roundtable members and other attendees to have your questions. If you could identify yourself first.
That you have a health literacy assessment. I'm wondering, how is health literacy assessed? And then I guess my follow-up to that is a health literacy assessed patient a health literate patient?
So the standard in our patient-centered medical home program is simply that the practice systematically assesses the health literacy of its patients. We're not prescriptive about how they do that. Clearly, at least to me, a patient who is assessed for health literacy is not necessarily health literate. What we're asking the practices to do is understand what their literacy capacity is, and then to appropriately tailor their communications to the patient. Now, we do say that if they apply something akin to universal precautions, that is, they use plain language, simple, low reading level for all of their patients, they don't have to do the specific patient assessment, and that counts.
Question?
Ernestine Willis at the Medical College of Wisconsin. I spent a lot of my time working in the community and hearing dialogue directly from everyday citizens to consumers, as we refer to throughout. And my lessons learned, and I want to hear all of the panels reflect to this, because this morning's session, as well as this afternoon, we keep talking about empowering the community. And I think we need to be very careful about saying that as far as empowering the community. I think you can definitely have community engagement, you can motivate, you can educate, you can capacity build, but I'm not sure you can empower. Empower means you give or you permit or you take away, and I'm concerned if that's our attitude, we need to be careful that you may send the wrong message, very paternalistic. We never talk about empowering leaders. And so, yes, many of these communities are under-resourced in ways that we can share resources or redirect resources in those communities, but we don't empower them. So I would just love for you to react to that. I know, Sarah, you were saying terms that I really could relate to, but I think we have to be careful how we communicate ourselves to this specific population.
So panelists?
I'll go first. I ditto what you said. I absolutely agree with you, and I try very consciously not to use the term empowerment because that is not what our role is as a policy organization. We work very closely with organizations that I think serve that role in terms of educating and working directly with community members to help navigate through the system to better understand it. When, a lot of them are legal-based organizations, some of them are promotoras and health navigators, and I think even their role, I think many of them wouldn't even consider their role to be empowerment either. It's really about education and awareness. And I even hesitate to use the word capacity building too, because I think everyone has capacity. It's more again sharing the kind of knowledge that again helps. As we've been working with many of the community groups through the implementation of the Affordable Care Act, what has become very what has been highlighted very much is that our system, our culture of coverage. Is very confusing, and it's very fragmented, and I think we ourselves have a very hard time navigating, and for somebody who, again, doesn't speak English very well or who is very new to the country, to try to understand not even the term co-payment or co-deductible, but even to just, when you're trying to choose a health plan, when you're trying to actually access their coverage. Some of our community-based organizations have spent hours on the phone, even just trying to understand if somebody has coverage or, why there was a glitch in the system. So we're very far from the term empowerment. Where I think our key role is really to pass on the information, to work directly with our patients and with our populations, to try to be that intermediary or that liaison to the extent that we can. And then I think for an organization like ours, it's really trying to educate both government agencies that we work with, as well as our research partners and our policymaker partners, to even better understand what the role of some of these community-based organizations are, and to push as much as we can to make sure that consumers have a seat at the table, that they're represented, and even not that it's community-based organizations, but that it's actual consumers who can be at the table.
I wonder if it's more a matter of language among the different speakers and audience members today, and if we really agree upon the guts of it though. So for example, information is important, but it's not enough. So I think some of the speakers have made the point that like chronic disease, most of it, 99% is basically self-management at home. And so like the various programs that we do in education is information, but then we also try to work on the self-efficacy piece. So people, feel more confident to be able to sort of take charge at home and all. or, when we do work with community partners on like healthy food and exercise and all, same type of thing of thinking about like what are the different strengths that everyone can bring to the table in partnership to try to make it so that it's more likely that a diabetic patient will have access to healthy food or a safe place to exercise. So I wonder if it's more we reap on the concepts, but then we're just using terms different ways.
Yeah,
Dr. Rosa?
if I may, thanks. I would agree with Marshall. I think that, and I appreciate your question, and it's a very important one because the words matter. When I use them, and I think when, Dr. Benjamin used them, when the NPS came out, it was more of a sharing of education, of access, of insight. And unfortunately, in the past, it was a very top-down, the way doctors stood over patients and told our community members and our patients what was best for them. So I know personally, when I use that word, it's a leveling of what was a particularly patriarchal process in the past. And I think most of us would probably use that word that way, that it's changing a system that we've learned is not particularly effective in good patient and good health outcomes, and instead sharing. I practice cardiology and see only women patients. Empowering my OBGYN partners to learn data that's come out in my world to better take care of their hypertensive pregnant woman is empowering to them. My understanding what goes on in a labor and delivery suite, oh my goodness, is empowering to me, and the end result is better care for the shared patients or the shared community members.
So we have one last question. If I could ask you 30 seconds and then 30-second response.
Okay, so we've talked a lot here about facing the community. Can we talk, or the healthcare system facing the community? But what happens in the classroom is, in the exam room, is the doctor doesn't face the patient, it faces the computer. And the computer systems have all kinds of patient education stuff embedded in them that are totally inappropriate. And so you're talking about systems here. Can you talk a little bit about addressing that? Maybe Stacy has some stuff about what they've been doing in their system.
Yeah, no, it's a great question. I spent a lot of time apologizing. I can't type. I took driver's ed instead, and I still use one of those little Levenger's white notepads that so I can talk to a patient rather than, but it's difficult. And I think much of what's embedded in the EHR is difficult to find, which is often a good thing because some of it is, inaccurate and ineffective. And I think in our practice, certainly in our women's health initiatives, we're almost doing siloed activities within our Office of Community and Public Health with all of the patient education materials that we're creating is not solely that which is embedded in the electronic medical record. So we are making or partnering with the American Heart Association or Women Heart, for instance, to get acceptably well-written, health-literate, tenant-based materials for our communities. I think the blessings and challenges of the electronic health record are there for all of us to manage. Every time I'm frustrated when I can't find something, the beauty of finding the x-rays interpretation by the pulmonologist across town makes me smile a little bit. But I think for most of us with, still beginning generations EHRs, we need to not take satisfaction that patient education responsibility is taken away from us through use of the record.
One of our faculty, Wei Wei Lee, has actually developed a niche of how do you teach patient-centered care with EMR. So basic stuff like having the screen in a triangle so that the patient can look at the screen together, asking questions and showing the data on the screen, not looking at the screen when you're talking about, a sensitive issue or a mental health issue, for example. So it's not great, but under the current system, it can be at least that improve.
So let's continue that discussion in the small groups and join me in thanking the terrific panel.
Once again, as far as I'm concerned, this is a wonderful, superb presentation with really on-the-ground, cross-cutting efforts that are very, very real, very impressive, and certainly could make benchmark opportunities for further work. Really terrific, and I thank you very much. We'll now be dividing up into small groups to address issues related to integration research in policy and services and care. so I need your attention to this one. When you get in your small groups, please identify a person within that group who will take notes and a person who will summarize the group's discussion when we return for our general discussion and our general session. Each of you has a colored dot on your badge. Those with blue dots will be in the research group, which will be meeting in the Newport room. Janet Oheen Frampong will be your facilitator. Those with green dots on your name badge will be in the policy discussion group and will meet in the Balboa room, and Jem Dowse will be your facilitator. And those with red dots will be in the services and care group and will meet in the boardroom. Andrew Pleasant will be your facilitator. We will be back here at 3:30, so take your break during that time because we still have a reasonable amount of work to do for the remainder of the afternoon. Thank you.